These can be divided into two major headings. The static lung volumes and capacities, that is, time factor is not involved here. It is expressed as in ml or liter. The dynamic lung volumes and capacities, which are time dependent, and they are expressed in ml per minute or liter per minute. Coming to static lung volumes and capacities. Tidal volume. It is the volume of air breathed in or out of the lungs during normal quiet respiration. The normal tidal volume is around 500 ml, and the tidal volume increases in muscular exercise and it decreases in respiratory muscle weakness or depression of respiratory center. Inspiratory reserve volume, that is IRV, the air inspired with a maximal inspiratory effort in excess of the tidal volume, that is the maximal volume of air that can be inspired after completing a normal tidal inspiration. The normal inspiratory reserve volume is 3.3 liters in men and 1.9 liters in women. Expiratory reserve volume, that is ERV, the volume of air expelled by an active expiratory effort after passive expiration, that is the maximal volume of air which can be expired after a normal tidal expiration. The normal ERV is 1 liter in men and 0.7 liter in women. Residual volume RV, the air left in the lungs after a maximal expiratory effort. The normal residual volume is 1.2 in men and 1.1 liter in women. Closing volume. It is the lung volume above residual volume at which airways in the lower dependent parts of the lung begin to close off because of the lesser transmural pressure in these areas. And pulmonary ventilation, that is minute ventilation, is the amount of air inspired per minute. Normal resting minute volume is around 6 liters, that is 500 ml of tidal volume into the number of breaths per minute will give you resting minute ventilation. Coming to capacities, capacities can be inspiratory capacity IC. It is the maximal volume of air which can be inspired after completing tidal expiration, that is from the end expiratory position. Thus, the inspiratory capacity can be given as TV plus IRV. Normal inspiratory capacity is 3.8 liters in men and 2.4 liters in women, and the range is between 2.5 to 3.7 liters. Expiratory capacity, it is the maximal volume of air which can be expired after completing tidal inspiration, that is from the end inspiratory position, and hence the expiratory capacity can be given as tidal volume plus expiratory reserve volume. The normal expiratory capacity is 1.5 liter in men and 1.2 liter in women, and the range is between 1.25 to 1.5 liter. Vital capacity is the largest amount of air that can be forcefully expired after maximal inspiratory effort, which is frequently measured clinically as an index of pulmonary function. So these are the different waves we get on the spirometer. So these are the tidal volumes, inspiration and expiration, and this is the inspiratory capacity, which includes the tidal volume plus inspiratory reserve volume, and this is the expiratory reserve volume, and from here it is the expiratory capacity, which includes tidal volume and expiratory reserve volume, whereas the vital capacity is from the from the maximal inspiration to the maximal expiration. Okay. So which is nothing but the combination of the inspiratory reserve volume, tidal volume, and expiratory reserve volume. Advantages of vital capacity. It gives useful information about the strength of the respiratory muscles, Therefore, maximal inspiratory and expiratory efforts can be assessed. It gives useful information about the other aspects of the function through FEV1. So thus, as we discussed, vital capacity is a combination of tidal volume, inspiratory reserve volume and expiratory reserve volume. The normal vital capacity is 4.8 liters in men and 3.1 liter in women. Factors affecting vital capacity. Some of the physiological factors like physical dimensions, that is the size and the development of the subject. The vital capacity is more in males than the females because of the large chest size and more muscular power and more body surface area. As age increases, vital capacity decreases due to the loss of elasticity of the lung. It also depends on the strength of respiratory muscles. The vital capacity is high in swimmers and divers. Pregnancy decreases the vital capacity. The posture, in standing position, vital capacity is more than the sitting or lying down position. Some of the pathological causes where vital capacity decreases are disease of respiratory apparatus, for example, poliomyelitis, pulmonary fibrosis, pulmonary edema, and pneumothorax. And ascites and accumulation of the fluid in abdominal cavity also leads to decrease in the vital capacity. Functional residual capacity, it is the volume of air which is contained in the lungs at end expiratory position, that is after completion of tidal expiration. That is why functional residual capacity can be given as residual volume plus expiratory is the volume. The normal FRC is 2.2 liters in men and 1.8 liters in women. Total lung capacity, it is the volume of air contained in the lungs after maximal inspiration. And thus, total lung capacity can be given as vital capacity plus residual volume, or total lung capacity can be tidal volume plus inspiratory reserve volume plus expiratory reserve volume plus residual volume. Normally, the TLC is 6 liters in males and 4.2 liters in women. Maximum voluntary ventilation or maximum breathing capacity, that is MVV, is the largest volume of air that can be moved into and out of the lungs in 1 minute by voluntary effort. So normal MVV, that is maximum voluntary ventilation, is 125 to 170 liters per minute. Breathing reserve or pulmonary reserve is nothing but the maximum amount of air above the pulmonary ventilation which can be breathed in or out of the lungs in 1 minute. So breathing reserve is maximum voluntary ventilation minus resting minute ventilation. Coming to dynamic lung volumes and capacities. Timed vital capacity or forced vital capacity. Forced vital capacity is the maximal volume of air that can be breathed out as forcefully and rapidly as possible following a maximal inspiration. The time vital capacity is similar to vital capacity except that there is a special stress on the rapid, forcible and complete exhalation. Components of time vital capacity are FEV1, that is the forced expiratory volume in 1 second. It is the fraction of the vital capacity expired during first second of forced expiration, or it is a volume of FVC expired in first second of exhalation. Normally 80% of the air is expired in first second, so it is around 80% of the FVC. And FV2 is forced expiratory volume in in 2 seconds rather. The volume of the forced vital capacity expired in first 2 seconds of exhalation. Normally 95% of the air is expired in first 2 seconds. FV3 is forced expiratory volume in 3 seconds. The volume of FVC expired in first 3 seconds of exhalation. Normally almost 99% of the air is expelled by the end of third second. Some of the clinical significance of forced vital capacity. It is used to distinguish between restrictive and obstructive lung disorders. Restrictive lung disorders where chest expansion is restricted, so the vital capacity decreases while FEV1 is normal. The TLC mean maximal voluntary ventilation also decreases as vital capacity decreases. For example, kyphoscoliosis, ankylosing spondylitis, that is the arthritis of vertebral column. Obstructive disease, here the inspiration is normal, but the expiration is obstructed. So vital capacity is normal while FEV1 decreases. For example, bronchial asthma and emphysema. Okay. So this diagram showing the dynamic lung capacities, that is the timed vital capacity, and this is showing the forced expiratory volume, and this is the amount of the volume expired in the first second. Almost more than 80% of the air is expelled in first second, and almost more than 95% of air is 95% of the FVC is expelled in second, and almost 99% of the FVC is expelled in the third second. Note that FE1 is a much more sensitive index of severity of obstructive lung disorders, but it does not allow for the differentiation of the various causes of the obstruction. And this diagram showing the forced vital capacity in 1 second, that is FEV1 in normal and restrictive and obstructive lung disorders. In normally, in first second, more than 85% of the air is expelled, where in restrictive lung disorder, rather vital capacity is reduced, but the FEV1 is going to remain constant, but FEV1 to forced vital capacity ratio sometimes may be increased or may be normal. But in obstructive lung disorders, the FEV1 drastically reduces. Less than 70% of the air is expelled in first second, and the FEV1 to forced vital capacity ratio is also increased in obstructive lung disorder. And that is how you differentiate restrictive lung disorders from